Pertanto, uma coisa a fazer a gente. Até.
We are about to start. We are about to start. Just giving access to all the participants that are getting connected. In very few minutes, we're starting.
Ya voy.
So we are on time, just in time. Please let me know if my audio, microphone, and screenshot is okay. If there is any problem, just let me know. Good afternoon.
Ya tenía planes también, ¿no? Buenas noches, vamos a salir a cenar. Ahorita justo no te contesté porque estoy esperando que el estudio me ha mandado un postre con un jugo.
I'm going to mute
We
all the
can look at your
settings.
presentation.
Okay. I just accept the recording option and the transcription option too. Okay, so good afternoon to everyone in Peru and Latin America, and good evening and good morning for all the attendees from other countries around the world. I'm Dr. Norville Melachu, the current ICO National Secretary of Peru, but today I'm not here just as Peru. I'm here as part of the ICO member from Latin America who would like to welcome all of you to the webinar titled Safety and Health at Work Month, the Impact of Digitalization and Artificial Intelligence on Workers' Health, which is a joint effort between the Scientific Committee of Occupational Medicine of ICO and the National Secretary of ICO in Peru. Back in 2003, the International Labour Organization started to commemorate this date, this April 28, as the World Day of Safety and Health at Work, to increase awareness about the importance of preventing occupational diseases and accidents. Over 20 years, after over 20 years, we have that this date, this April 28, is considered as part of the global strategy of the International Labour Organization to keep working on the awareness about how the prevention culture, the health promotion can be a tool, can be a key to decrease the work-related deaths and injuries. So I would like to start this webinar thanking the speakers that will be part of this, but also giving this message. In Peru and Latin America, we have got some advances, not only in politics and legislation, and also in big companies, but also in small and medium-scale companies that has been working in occupational health and safety systems. But we still need to work more because there are some sectors such as fishing, agriculture, and some industries where we can still found significant number of job accidents and diseases. So we would like to start this webinar with this message that we have to remember that to prevent is to decide to live. And even though all the job that we still need to do you want to be part of this change? So to be part of this change, we have to keep in mind the message, the main message that the International Labour Organization has given for this year, which is revolutionizing health and safety, the role of artificial intelligence and digitalization at work. So with us, there are some national secretaries from Latin America, and I would like to invite you to give some few words about the importance of this month and day. So I would like to introduce you to Dr. Adriana Radim Arias Pereira, who is the current Brazil National Secretary of ICO. Welcome, Dr. Adriana.
Hello, all. Dr. Norville Merachu, thank you sincerely for a kind invitation and for the opportunity to attend this important event. Dear esteemed colleagues, friends, it's an honor to be with you today as we mark once again the month of World Day for Safety and Health at Work, a date that reminds us why we have chosen this profession, to protect lives and promote dignity in the world of work. This is the impacts of digitalization and artificial intelligence on the patient's safety and health challenges us to look carefully at how technology is reshaping the world of work. AI brings undeniable opportunities, predictive systems, better risk controls, and new tools for prevention. However, it also brings new and complex risks. especially psychosocial burdens, surveillance, job insecurity, and inequality. In Brazil, we are especially aware of these challenges. Over 6 million workplace accidents were officially recorded between 2012 and 2022, with more than 2,000 deaths. In 2022 alone, we had more than 612,000 accidents, and we know underreporting hides the true magnitude, especially among informal workers. As we integrate AI and digital tools, our mission must be clear. Technology must serve workers, not the other way around. The future of work must be human-centered, prioritizing safety and health and inclusion. And let us not forget, every accident prevented, every life protected, every risk managed is a story that continues. It's a family that remains whole, a worker who returns home safely. As we reflect on this, I would like to close by recalling the words of a Brazilian educator, Paulo Freire, who once said, "Technology is not neutral. It will always serve those who hold it in their hands." Traducindo al español, la tecnología no es neutral. Siempre servirá a quienes la tengan en sus manos. So it's up to us as ICO professionals to ensure it serves life, health, and social justice. Thank you very much. Gracias, muito obrigada.
Thank you, Dr. Adriana. And we also have the presence of the National Secretary of Colombia, Dr. Diana Cuervo. So welcome, and we would like to hear some words about you, about the importance of this date, please.
Good afternoon, everybody. I am Diana Cuervo from Colombia. I am occupational physician, and I work in the National Disability Rating Board in Colombia. For me, it's a pleasure to be in this webinar. It's a pleasure to celebrate the occupational physicians activity. We work with the most beautiful human rights, health, and work. Para mí es un orgullo estar en este webinar en español, porque los médicos ocupacionales trabajamos con dos derechos humanos maravillosos que son la salud y el trabajo. Soy médica ocupacional, doctora en salud pública en Colombia y trabajo en la Junta Nacional de Calificación de Invalidez adscrita a mi trabajo. Gracias. Thank you very much for inviting me.
Thank you, Dr. Diana. And we also, and finally, last but not least, we have Dr. Osana Rodriguez, who is also the National Secretary from ICO, Mexico. Welcome, Dr. Osana. We would like to hear some words from you.
Muchas gracias por la invitación, doctor Norville. Encantada de participar y compartir con mis compañeras Adriana de Brasil y Diana de Colombia, tan queridas ambas. Es para mí un honor estar en este webinar en donde celebramos o conmemoramos el Día Mundial de la Seguridad y Salud en el Trabajo, ¿no? Creemos conveniente este tipo de webinar porque nos acerca como profesionistas interdisciplinarios, ¿no? Tenemos que trabajar en conjunto, médicos, enfermeras, ingenieros, prevencionistas, etcétera, por la salud de los trabajadores, ¿no? Y este tipo de webinars nos acercan a conocernos, a saber qué estamos haciendo en los diferentes países. Como bien lo comentaba la doctora Adriana, si no conocemos el contexto, pues no podemos trabajar en ello, ¿no? Entonces, esta es una invitación a que nos acerquemos todos a este tipo de contextos de intercambios y que podamos conocer qué sucede en nuestro país y difundirlo a otro país y quizá aprender de todas esas buenas prácticas que tienen en otros países y replicarlas en el nuestro, ¿no? Entonces, es un llamado a todos ustedes a reforzar esos lazos entre países, sobre todo en esta bella Latinoamérica, de lo cual hay mucho que trabajar en la salud ocupacional. pero creemos que podemos avanzar si nos unimos todos de la mano en favor de la salud ocupacional en Latinoamérica. Muchas gracias. Soy la doctora Osana Rodríguez, secretaria nacional ICO México y actualmente presidente de la Asociación Latinoamericana de Salud Ocupacional, ALSO. Muchas gracias.
Thank you, Dr. Rosana. And well, for starting, we will, excuse me. Okay, it is my pleasure to introduce you to our invited speaker, Dr. Ismail Nabil, who is a distinguished expert specialized in internal medicine, occupational and environmental medicine, and clinical and bioinformatics. He is profoundly committed to advancing the health and well-being of workers and diverse populations through innovative perspectives and solutions. His work focuses on identifying risk factors associated with climate change and other environmental determinants that affect human health and disease, particularly within the realms of occupational health and environmental medicine. A key area of Dr. Nabil's expertise involves his involvement in the World Trade Center Health Program, where he applies his knowledge to improve outcomes for individuals affected by the World Trade Center tragedy. Additionally, he is deeply invested in exploring the impact of climate change on the health of working populations and addressing occupational and environmental diseases. As a pioneer in integrating information technology into healthcare, Dr. Nabil leverages artificial intelligence, large language models, and unstructured data analysis from electronic health records to revolutionize occupational and environmental medicine practices. His groundbreaking use of the artificial intelligence not only enhance diagnostic and treatment protocols, but also facilitates comprehensive data-driven strategies to mitigate health risk and diverse work environments. Through these efforts, Dr. Nabil is at the forefront of promoting systemic changes that foster a healthier and more sustainable future for workers globally. He also takes pride in producing the American College of Occupational and Environmental Medicine's podcast, OCPOD, which develops deeply into topics related to the field of occupational and environmental medicine. It is my pleasure to introduce you, Dr. Ismail Nabil. Welcome, Dr. Ismail.
So much.
I will stop sharing that.
Yeah, I appreciate the introduction. Thanks. I'm going to jump directly into the slides. Thanks so much for joining me today. You can see my slides now. Wait.
Yes, we can see it.
Thank you. So thanks for the invitation. I'm really excited to sort of dig deeper on the topic of artificial intelligence, and particularly how we have incorporated it into occupational environmental medicine. And at the time when I started the work, like eight years back, it seems a foreign land and a foreign word for most of us, but now it's in the vocabulary and the jargon on an everyday basis. So the work is basically almost spanning 8 years. So it's good to sort of summarize this in our talk. So some of the things that I just wanted to explain is that we're going to look at AI, artificial intelligence, and how it can be applied into occupational environmental practice. And the second part is how do you gain insights into sort of a specific use of artificial intelligence, particularly for pain analysis, pain characteristics in musculoskeletal disorder. And like a clinician, which I am, will go through a case to go through a better understanding of how it can be applied. And then finally, how you can apply, how you can sort of at whatever level you are in AI, how we can integrate that into our work, into our research, and into helping patients. So let's start with a case. This is a real case. Of course, the names and places have been changed to make it more anonymous. A 43-year-old operating room technician, Sally, was working in the OR, and she slipped and fell early in the morning while she was coming to the OR. At night before, the whole deep cleaning was done, so the surface in the OR was fairly slippery, and the floor was just wiped and cleaned. When she fell backwards, hit her back, and since then she was in significant amount of pain. So I know most of you are occupational medicine docs, and lower back pain is one of the most common thing that you see on a regular basis. So this is just kind of give you a little brief anatomy of the back. So she's basically, at the time she had disc herniation, she has significant amount of pain, and a little bit of movement of the bone, spondylolisthesis, and then she has a dermatomal disease of the pain as well, which shoots down from the back into the leg. Sally has underwent sort of assessment at the time, and turned out to be that she had disc herniation, which was noted in the MRI. So at least from the US side, low back pain is one of the most common thing that people see in practice. And one of the most challenging diagnoses that we see in our practice, both occupational and non-occupational cases, are significant. There are about 3.5 million people impacted by degenerative joint disease, intervertebral disc disease, and it's a huge amount of money that gets invested in treating lower back pain. And the problem is the lower back pain is not one size fit all. There's degenerative joint disease, there's scoliosis, spondylolisthesis, arthritis, spinal stenosis. Some of the younger folks in pregnancy can have lower back pain, kidney stones, infection. So lower back pain is not a singular diagnosis that one presents with, but rather it's a challenging one. And then it morphs into fibromyalgia and other kind of conditions that are more vague. But as far as disability is concerned, I think I heard some of the folks are work on disability. One of the most common reason for having disability or long-term disability is arthritis. And one of the most common conditions that we see is back and spine problems that we commonly see in our patients, and that leads to more disability. So lower back pain is a significant challenge and problem that we need to address. One of the things that we have seen as occupational medicine docs is if we can start mobilizing these patients early on, we can have a very good response to lower back pain. So more mobility, getting them off the bed, sort of treating their pain and sort of mobilizing them really helps in improving their outcomes, particularly for lower back pain. And one of the challenges we also see is most of the lower back pain visits are not to a specialist, but to family doctors or primary care doctors who are seeing these patients on a regular basis. I work for Mount Sinai Health Systems, and we have a huge geographical footprint. This slide's a little bit old, but we basically covers most of the area in Manhattan, Bronx, and lower down into the Midtown, as well as some areas of Queens, Brooklyn, and Staten Island. So the idea was to initially, about 8-9 years back, we decided to really educate the primary care doctors who work in these boroughs to understand lower back pain and ask them to work with their patients so they can have effective treatments and they can come back to work after lower back pain. So we have a non-occupational medicine trained provider who we were asking them to work with their patients and get them back to work, which is our primary functions. And we also provided them with evidence to support that the return to work is one of the most important things that you can do for your patients. and it can improve um, the lower back pain symptoms. It will minimize acute on chronic presentation of lower back pain in their patients. And we know this as occupational medicine trained physicians, both ACOM guidelines, ODG guidelines support that bringing them back to work or starting return to work early in the process really helps in reducing disability in lower back pain patients. So the big question they all ask me, all the internists, all the family medicine docs that we were working with, like how much it is that the case that if you bring them back to work or you mobilize them early on, um, is there a randomized control trial? Is there a good evidence to support that individual can return back to work sooner and they have improvement in their lower back pain? And there's multiple studies that actually support the notion that mobilizing them early on is fairly beneficial. The challenge with the primary care practices that don't usually deal with return to work options, so they were very hesitant to do such a thing. Coming back to Sally, things didn't go really well. She has significant amount of pain that changed from acute pain to chronic pain, acute on chronic pain. She got the injections in the back of the spine that helped a little bit, but didn't fix the problem at all. She finally got the fusion surgery, basically lower back, and ultimately became significantly painful to do work, and ended up sort of getting disability from work because she cannot perform the same job functions that she was doing as a OR technician. So going back to the work that we started, we wanted to see how many lower back pain patients that providers see in a practice, and then we can provide them with intervention. And the story is that we can help these low back pain patients come back to work, and we can reduce their mobility, reduce their disability, improve their mobility. But the problem is that the amount of lower back pain patients that primary care sees varies with different providers. If you have urgent care practice or you have primary care practice, that's a different kind of lower back pain that you see on a regular basis. Other problem is it acute low back pain? Is it acute on chronic low back pain or a chronic low back pain that people see in their practice? So, and then as I mentioned, that lower back pain is not a single entity. This one is 81 potential ICD-10 codes that we see in diagnosis of lower back pain, from myalgia to muscle spasm to different kind of degenerative joint disease that we see in our patients. The other challenge was the variability opportunities that we have. We can change the lower back pain. So I'm a clinician with a very good understanding of electronic health record. This is a couple of years old electronic health record called EPIC. We use it extensively here in the US. And what we did, we designed a simple way for the primary care doctors to prescribe return to work options for their patients. And it seems to work really well. They have ability to characterize lower back pain and then specifically provide interventions for their patients. So this first attempt was to build a system within the electronic health record. The second part was we randomized our work. We asked the interventional group, we gave the tool that I just showed you, and the other group was a control group that did not get the tool to prescribe return to work within the electronic health record. As you can see, the group that was interventional group did exceptionally well in terms of bringing patient back to work. The control group did not do really well, and this was a statistically significant difference that we saw in our study. The bummer was the majority of physicians did not feel that they have the ability to prescribe return to work for their lower back pain patients. And the problem was the majority of time they keep telling me that we don't know if it's an acute pain, acute on chronic pain, or a chronic pain, because the codes are all the same. Lower back pain M54.5 is the ICD-10 code, which is exactly the same for acute and acute on chronic pain. So we cannot differentiate just by looking at the codes. And the challenge they kept telling me is, I'm not in the practice to see the patients with them. But yet I'm prescribing them, or I'm giving them the tools to prescribe, which becomes really challenging for them to use. So the problem was, at the time when we were thinking, if I want to influence the providers 81, 90 practices that we were working with, how do we scale that up? I cannot see individual patients each time. So we decided that there's other ways to do it. And that where the AI or artificial intelligence came into being. This is a clinical decision support system, which is commonly used in electronic health record. Anything that you do, any decisions that you make in electronic health record usually follows this very rule-based CDS systems that you see. It's a very cumbersome system. It basically gets deployed in the electronic health record in a way that it first gets constructed into a CDS module, and then it gets deployed into electronic health record system. So it needs to be constructed and deployed, and it requires a lot of work from the behind the scenes to make it more functional. But it's a rule-based system. So if you have lower back pain, such and such thing, it's going to happen. Otherwise, the system doesn't work. But the problem with any work is the variability, the edge cases, the things that people see in the practice is very different than a rule-based system will not work. We need something that's much more different and much more reasonably has a way to do things, right? So that brought me to artificial intelligence. We started to recognize that the machine can understand how you talk. And one of the early work that was done in computer science, it was natural language processing. So what happens is the computers just start to understand what you're saying, what you're talking about, and can make interpretations of the work that you're doing. So this is a good example where the person on the left, you can change the vision, starts from one picture to another. The second is a Stanford example where a person who have never danced before, the computer can allow them to dance really well. So AI can really change the way how you do things. So we started with that goal. It was simple. We will figure out what are the primary care doctors are seeing in the practice. And our target was acute low back pain. We were focused on looking at just acute lower back pain. Any intervention that we do for chronic low back pain doesn't work. So we need to start with something very basic. And the idea is if we find acute low back pain, we can then inform the physicians or providers to do interventions, to basically prescribe return to work options for their patients. So it was a simple process, but it was very complex. We used unstructured data, which is called physician notes. We also used ICD-10 codes, but we felt that unstructured notes basically gave us the better example of what the patient is dealing with. And so, for example, this is a good example. Most of the physicians write pretty short and quick. So out of all the gibberish that we write every day, this was something that need to be deciphered, right? So if you are familiar with the way you write, deciphering this information means that it's a 24-year-old female who presented with low back pain for the past 2 days, and patient has been referred for physical therapy and to follow up in 2 weeks. This is a profound statement. It gives an idea of what the age of the patient is, how many days the pain is, so it's acute pain, and what was done was referred to physical therapy, and the follow-up is in 2 weeks. So it's a very good case for intervention. But the problem is the computer don't understand these shorthand language that we use on a regular basis. But we have this natural language processing. We were confident that we can train computers to learn how we write and how we speak. So we started with NLP, but the NLP was natural language processing does give us a semantic understanding of what the note is written about. But the challenge with to expand it is that the machine also have to learn what's happening, not only extracting the words, but also making sense of it. So this is a very simplistic design of a machine learning neural networks or machine learning algorithms, what we call it neural net. Neural net is a bunch of sort of connected nodes that we use to make inference. It means that if we ask a computer what is this condition, it will go through a series of steps of decision making and then make a decision that this is something that we're looking for. It can classify it. So it's a good classifier, and it has multiple layers that we could use. So this is the very simplistic example of a neural net that actually allows you to make decisions and understand what we are asking for. This is early work in terms of neural net. This functions just like how we think and how our brains are connected with neurons. So think about all these neurons working together to make a diagnosis. So we use neural net in our work to start with. But the challenge is significant. We also realize that the lower back pain doesn't come in one shape or form. Some people call it sudden back pain, spasm back, low back pain, or sciatica, or people use treatment options to describe lower back pain. So it's not a one system that we can build our computer model and then extract or classify acute low back pain. So there's many things we need to understand and to add for. The other thing we were disappointed to see that the commonly used ICD-10 codes, which is in this case, are not the reliable way to understand the acuity of pain, as I described before. Even though we described a condition through ICD-10 codes, it does not give us an understanding of what is exactly going on with our patients. It's just good for billing, but not necessarily good for clear understanding of how patient is dealing with. So we build this whole intense framework. We actually extracted about 15,000 records with 17,000 notes. We actually divided them into IC10. We annotated means that we looked at each note, about 4,000 of them, and basically labeled them as acute pain or not acute pain, and then trained our artificial intelligence to pick up the right way or classify the lower back pain. So this process was then able to identify and decipher acute pain, acute low back pain, and was able to do it with the help of CovNet, which is a neural net network. So essentially, we have designed a computer program or model that can differentiate between different kinds of pain, particularly for lower back pain. It can say it's an acute low back pain versus not an acute low back pain. And that model worked really well. We didn't even use the IC10 codes. We used clinical notes to make a decision. And if you read through notes, or at least treat your patients, you know that clinical notes gives you a good understanding of what the patient is dealing with. So we can, with that information, with that model, which is very successful, we thought that we can work on building targeted approaches for lower back pain patients. And it can be expanded further to shoulder or knee and other clinical domains. But the challenge was immense. During that time, a pandemic happened, and all our work was pushed towards helping our patients deal with the pandemic. And so the program was stalled. And by the time we started back on, there's a whole new design of artificial intelligence started to emerge. So this is a 2017 paper from Google, which is called Attention All You Need, is basically the birth of the ChatGPT that you see. This is the architecture that is used to build ChatGPT from ground up. But it was a paper called Attention All You Need is the primary genesis of the work that you see. This architecture is called Transformers. It's not the Transformer movie that you have seen, but it transforms the things into a more manageable, readable way. So what you can do is you can actually translate in English to Spanish, to German, any language. So it transforms the things that you read and write. And it's a very powerful platform, a model that we have not seen before. So at the time when we were working on this project, which was early 2022, 23, we came across like, can we use the transformer model to do the same exact thing, like extraction of musculoskeletal pain disorders from electronic health records, and then basically labeling it and seeing if the transformer can do a better job. So we did exactly that. We extracted notes and labeled them, and then let the AI trained on them. And then we looked at all the patient notes. We labeled back, knee, and shoulder pain. So this time we were ambitious. We said, I don't think we can only focus on the back. We can actually, with the tools that we have, can we look at acute knee pain or acute shoulder pain? Because the treatment options for knee and shoulder or lower back pain are different for acute cases compared to chronic cases. And then labeling them into acute on chronic, and chronic low back pain. So definitely an ambitious task for and a challenge for artificial intelligence to understand and reproduce and classify these conditions in the Go. But we were pleasantly surprised. So this is kind of a busy diagram, but let me take you through it. So Llama 7B at the time was one of the biggest model, like ChatGPT was released just a couple of weeks back at the time we were doing this work. And Llama was released as an open source model. One of the things that I should tell you is I work with electronic health records. There's information that I cannot send it to any service or any systems, and I have to build every single thing internally. So we basically have complete confidentiality regarding patient cases. So Llama, that's been released by Meta, was completely open source, and you can download it in the system and build your pipelines or your system internally, and no information gets out from your system within where I've been working on. So first, what we did was we actually trained the model and helped them understand what is acute on chronic and chronic. And then we also give information to this model to say if it's in the shoulder pain, back pain, or knee pain, or it's other kind of pain. And it was instructional based. So that we actually use simple instruction, just like you put your question in ChatGPT. We actually use the similar model and give input to these big, large language models and say if you can decipher it's acute pain or chronic pain. And model did exactly that. It actually generated responses for us. It's the chronic shoulder pain. It's a chronic knee pain, which is completely out of the blue because we have never seen this kind of understanding from the computer that they can now understand at a visceral level what we're asking for. And that was not it. The kicker was, I don't need to build each model separately. We can actually build one model and can ask the same question for lower back, for knee, or for shoulder. In this case, this is an example of a chat. So behind the scene, there's a big, large language model responding to the queries, just like ChatGPT. And what you can see is we can not only ask a question about chronic shoulder pain, but we can ask if the person has received chickenpox vaccine, and which is very, very significantly powerful because that allows us the ability to expand to any clinical realm that was not possible before. In order to solve problems before, we have to build each model separately, and that requires cost, expertise, and clear understanding of the domain. But here, it's agnostic to any particular domain, and we can solve problems. This was the first time a foundational model, which we call like a ChatGPT without significant training, we can solve problems within clinical domain. The paper was published at Lancet Digital Health in November of 2023, one of the earliest work that we did on large language model. And one of the challenges that we saw which is highlighted here. Most of us write very short notes, which you can see right here. And these notes are not really give you an idea about the condition more. Most of the notes that is written are between 1,000, 2,000 tokens or words, which gives us much more better enriched idea about the condition and note. So this is where the focus is. But the problem, early LLMs or large language models or programs like ChatGPT did not have the resources to really process these kind of that amount of words. So a model like a 7 billion parameter model like Llama will take 2 or 3 weeks to process the information on a high level computation. So which is insane, right? So you basically run your computer for 2 weeks straight, a very high-end computer for 2 weeks straight, just to get the answers that you're looking for. But at that time, that was the only way you can process this information. So just to give you an idea, the model did perform excellent on all levels. Shoulder pain, low back pain, it actually provides a very good understanding of sensitivity and specificity. You also have a good recall, and specificity was also pretty good. And we were able to decipher with reasonable certainty that this is acute pain or chronic pain. So that was the initial work that we did. But then I started to explore more in the sense of how generative AI, which we have used earlier, or the generative AI or LLMs are used in all specialty. And if you look at the left, you won't find occupational environmental medicine practices, because majority of times more traditional medicine domains have been using generative AI models. And then there's a specific generative AI models that are commercially or open source models that are available. But majority of cases we see epidemiology or biostatistics are predominantly where the generative models are used. Then I'll bring you in as in 2025, what is now happening with large language model. We have now been to a place where it needs no introduction. People use it on a daily basis. It's been part of our vocabulary for a very long time. But I want to show you what exactly going on behind the scenes, so at least you have a clear understanding of how large language model is working. And there's more data information is coming out almost every day. So let's talk about the ChatGPT that you use on a regular basis, just interacting with the model. These are called simple response LLMs, which gives you generic information, basic facts without personalization, and some level of recommendations that you see. The second part of the model that has been evolving now, it's called chain of thought models. So just like what we think, the models and these artificial intelligence can think. They have visible thinking process. They look at multiple causes or scenarios, ask clarifying questions from you, and then provide a structured response. But the really mind-blowing part that I think has changed everything is called reasoning models, which are reasoning LLMs. They employ systemic sort of clinical reasoning, build differential diagnosis framework, and probability trees. And then they're a lot more robust than what we have seen. They actually think just like us in terms of they can do reasoning, medical evaluations. They can also give you a differential diagnosis. So just to give you a perspective, here's a simple on the left-hand side, simple response model, which you ask a query, you ask a question, and it generates a response immediately, which is what we have seen in early models. The chain of thought models go through some degree of understanding of what exactly is, what are you asking, what are the conditions, what are the severity indicators, and then make a formative response in a sense that low back pain could be caused by multiple causes with duration, location, radiation. So it goes through the process of understanding what the question is. But what the mind-blowing part is, the reasoning model, which is now coming out more frequently, is where the model not only seeks to reason with you, but actually ask all the other questions or integrate other things into their vocabulary to respond to your question. So red flags, is there constitutional symptoms? Is there pain characteristics? Is the duration of progress that needs to be addressed? There's a functional limitation that you're asking, and then respond in a way that allows you to understand lower back pain, just like we do as clinician. Is it a burning pain? Is it sharp pain? It's a dull pain? Is it radiates down into the leg? So now you're differentiating in your mind, and then the large language model, like a reasoning large language model, does exactly the same to synthesize the response. Completely blows your mind away as you start to understand these models who are working and thinking just like you. So geek I am. I think I was early to think that I can build my own generative AI models, which I did. One of the reasons to build your own models because I work in a very restricted sort of HIPAA compliant space, and I want to control every single aspect I use. So it was a passionate way to build my own generative models, which I did in this example. But things are starting to evolve significantly. One of the things that I want to highlight is just like we learn from literature, these large language models also learn from the papers or nuanced knowledge that comes to them. So this is just to give you an example. This is a non-specific lower back pain and a paper on return to work. We can see that there's a lot of things that we consider in patients suffering from lower back pain. When we look at modified duties, we look at persistent symptoms for certain patients. We also look at psychological risk factors that can potentially cause that patient not to return back to work. So there's a lot of things that we consider to move forward. So how can I train the large language model to think like this? So there's a way to do this called retrieval augmented generation, called RAG. RAG was used to help not only the query, but also to extract knowledge sources and get relevant information from the knowledge sources. And then we inject it into LLMs and then get a feedback that is more responsive to the current knowledge about the topic. So RAG has become a more common understanding how we can improve on our large language models, which are not necessarily trained as doctors, or they don't have the knowledge, but we can really refine their understanding about the problem. So in simple response model, I want to give you an example. So the left-hand side is a human analysis, and then the right-hand side is an AI expert. This is a case of lower back pain. This is a claim case where the person has been injured while performing job functions, and she was caring for the patient. So the question I asked the large language model, again, a simple response model, is it work-related? And the answer is yes, this was work-related. And then it explicitly go through the process of what might be the alternative diagnosis, and then it summarizes the case for you to look at. So simple response, AI generation, learning as it goes. Now we look at the chain of thought models, similar kind of analysis. Now this time the patient was kicked by a person as she was leaving the hospital outside in the front hospital, and then the injury did not happen at work. So it's a little bit of a tricky case for AI to decipher, but again, it's a reasoning model. So, and it's a chain of thought analysis. So the query was the employee kicked? And then it went through the process of looking through each and every aspect, and then finally coming up with the answer called yes. It was indeed the injury the person experienced being kicked at work or not at work. We can also ask the question whether this injury was work-related or not, and then the response will be different. This injury was outside work, happened outside the work premises. So the model will also adopt the reasoning that it didn't happen at work. But the question here was employee kicked or not. Then we come to reasoning model and see how reasoning model does in terms of a more complex analysis. Again, this is a complex case, extreme lower back pain, has not been able to work. for a long time, and it's difficult for the patient to work after the injury. But the reasoning models start to ask different questions. Is the injury permanent? Is the injury work-related? What exactly is the injury? What is the prognosis? What's the final diagnosis? So initially, when the models start to ask you the questions, it goes through the iterative process of going through different things. As I showed you, that this model is not only looking at the previous research or papers, just like in the RAG that I showed you, it's also reasoning with it to see if it's a chronic pain problem or it's an acute on chronic pain problem. And then, so it's extracted relevant information from American Family Physician, which I provided to the model, and then went on to respond to the questions. What are the risk factors? What are the things that need to be considered in this case? Again, this is a typical case. Person has pre-existing condition, needed epidural injections. There was a lot of other things that was done, and she was not really well. And then the reasoning models start to provide a more comprehensive picture as it learns about the patient. It was second opinion was done with the spine center surgeon. So all these things contributed to a problematic case, or the person might not be able to return back to work. And then final analysis also takes into account psychosocial consideration and return to work challenges, which is how we think in terms of a case, and try to come up with a diagnosis or answer that why this person is not improving, why this person is not able to have a better outcome that we see. And so, but the model is also thinking the same way, and the return to work challenges have been identified. So finally, in a few words, we have an ability now to work with AI side by side. We can provide them with cases and real cases and train them into classifying new cases. We have a whole new arsenal in front of us, which allows us to understand our patient cases more viscerally. We can not only develop RAG models, which is a document that's previous research, we can also provide large language model to develop synthetic cases that can feed into their understanding and learning about the problem. We can train them on real cases. We can classify new cases. We actually we scale it up. We can look at not only 10 cases, we can look at 1,000 or 10,000 cases of low back pain and have a collective approach on what needs to be done to help these patients all along. So, and the reasoning LLMs have really changed the perspective in a sense of how we look at the problem. So in this case, the simple way to classify acute low back pain, acute on chronic low back pain, and then chronic low back pain. This is how we define these conditions or classification for our patients. And then large language models are also thinking the same way in order to classify. So in terms of the understanding, or there's a blurring of line between myself, how I think, and then the large language models is thinking. So let's look at the case of a 35-year-old construction worker lifting heavy objects. It's a sharp localized pain without radiation to the leg. He denies any numbness and weakness and tingling on other extremities. So right off the bat, it's a very structured case of a lower back pain caused due to heavy object lifting at work. It's a sharp pain. It's no radiation, so disc herniation is less likely. There's no numbness and tingling or weakness, so it's not a sciatic pain. Positive blood grazing test is positive, but there's only tenderness that's more localized. So right off the bat, this case could be, I can return this person back to work with modified duty, and the outcome will be great. So is the LLMs can see the same thing, and it does. It's a acute non-specific lower back pain, and it makes the case of why that is the case. And then finally, it also says, there's no red flags that I need to worry about. It's a 35-year-old male, which needs to get treated for lower back pain. And favorable outcome for these cases. So the idea is the simplistic design and these large language models can really take on a task of understanding condition and then providing options that only we used to think about by our knowledge or experience, but they're catching up. And finally, I just want to end with the fact that we do this OCPOD in one of the episodes on artificial intelligence, which allows you to dig a little bit deeper into other understanding. I didn't talk about all these things that comes with AI use, but I think there's definitely a case for you and your practices to use AI, artificial intelligence, in occupational environmental medicine practice to do more than what you can do currently. So thank you so much. I'll stop here and open things up for questions.
Thank you, Dr. Ismail, for sharing not only your background knowledge and this very interesting project with low back pain in workers, but also it could be very helpful for all the occupational health and safety professionals who are still getting in this artificial intelligence world that is so necessary today, up to these days. Thank you, Dr. Ismail. And please, we would like to invite all the attendees to make some questions to Dr. Ismail. We have Dr. Renato Vargas, who has raised his hand. I will ask to unmute. Okay.
Yes. Can you guys hear me?
Yeah.
Yes.
Okay. So, Dr. Ismaili, first, I would like to thank you for the presentation. It was quite interesting to let us know how we can take advantage of the AI intelligence in our daily practice. I have a question. It's mainly a concern because I've been particularly dealing with AI for specific matters, but when it comes to medical records, I have had a lot of red flags from the people from IM, who state that we cannot upload any medical record information into an open AI software. So you mentioned a little bit about Llama and how to download it and train it yourself in a local way to prevent that from happening. But to people we are not that used to handling it, what kind of sources we could use to analyze this information and train an intelligence and keep it quiet and keep it private for patients? Thank you.
So HIPAA compliance is one of the most important questions, and we definitely should take it very seriously. I would also discourage you to upload any cases in ChatGPT or ask any questions related to your cases, because the information is not protected, it's not controlled, it goes into different servers, and you can't control where the information was gone, and that could lead to things that we want to avoid. One of the things that I always think about is synthetic cases. So in cases, because we all are physicians, we see a lot of different cases. We can actually write up or build different synthetic cases that are not real cases, but portrays something that are more closer to real cases. Even in large language model training now, bigger companies like Grok and others, even OpenAI has synthetic cases. So that minimizes any kind of challenge that this real information has been used. So that's one that you can do with and limiting. You don't need to name any of those cases. These are all built by you. The second part is there are some ways to download, but you do need some degree of technical understanding of how you can use it. There are now open source LLMs, which can be directly downloaded into your computer. So there are servers where you can go in and download and then can run it. If you have some clear understanding of how to use them, you can actually run the whole thing on your computer. So we call it quantized models. These are 2 billion parameter model, which can be stored in 4 or 6 or 10 GB of space in your computer, and then you can run it. The other last option I have is basically a singularity option, or again, you need a little bit more technical information to download the model, but then you can house the model within your computer, which should be HIPAA compliant, or which should be within the space. Then you can use those to query your questions. But start with synthetic. Start with something that's very simple. I think just to test, just to have an idea about what you're talking about. Don't send anything that's proprietary or patient related to any of these big giants. So
Thank you. Thank you.
Okay, thank you. Thank you, Dr. Renato. If anybody else would like to make a question, please go ahead. So I would like to make a question, Dr. Ismail. Very interesting project about low back pain referred by workers. So using artificial intelligence, would it be possible to, at the same time, use for low back pain assessment and also ergonomical exposure risk assessment? Would we available to find a way to use both the symptoms and what is referred by the workers, but also the objective risk exposure assessment?
oh, absolutely. I have no doubt in that. So in the example I gave you, these workers were injured at work and had lower back pain. So if you understand a workplace, understand the exposures, or understand where the injuries are occurring, you can actually use artificial intelligence to glean that information and make a more informed decision. As I showed you, it can differentiate between work-relatedness or not. It can differentiate what's the cause of the pain was. It can also differentiate a simple lower back pain versus a complex lower back pain. So there's a lot of built-in information already being available. It's the challenge is how you want to use this to really help understand what the problem is. In cases, so if it's a safety sensitive position, it's a safety issue at certain workplace, or basically it's a problem where there's a susceptibility of injury. These models are pretty smart in terms of identifying that challenge in your patient population. So yeah, you can certainly query them or ask questions in the sense of how do you get to a place where you can understand where the challenge is now, how you can fix it. And it has a lot of options in terms of safety and health. It can give you understanding and information about a particular case, about a particular scenario. It can provide you with some of the basically an idea of how to move forward to address or manage those conditions. Yeah.
Thank you, Doctor. Even up to these days, occupational health and safety is still a challenge, especially for medium-scale enterprises and even more for small-scale enterprises, because it is supposed that bigger companies have, more income to invest. So if we want to start artificial intelligence and digitalization data in at least medium-scale enterprises. Based on your experience in USA, which would you recommend us for being, improving step by step?
So I look at that problem differently. I think a couple of years back, if you told me like we don't have the resources or we have a smaller company, we can't invest in research, we cannot invest in really learning about a particular area or place. I think things have changed radically. If you can work on collecting the information about work-related injuries or exposures, you can create a simple like Excel in a sense to really outline what the injury was, what was the exposure, what's the cause that you think, and then build that database line by line. In some ways, and you don't need to use any identifiers. You can actually just the numbers you can use to develop inferences. You can upload these Excels with just a simple idea about like you're looking at extraction of information. You can extract really graphs, understanding where the injury is occurring more, which areas are much more susceptible. So for example, in a furnace area, there's more burn injuries that you see in your worker population compared to areas where the steel or molten slabs have been placed to cool down. So the difference is there. You can see heat-related illness more in workers that are more closer to the furnace area compared to others. These are simple things that a clinician or a provider looks at it in the field. And you can extract that information, use it to build real inferences about your worker population. So there's more work to be done in the areas closer to the furnace to prevent heat-related injuries, to prevent burns in patient population, in the worker population. So that objectivity before was somebody has to have a good understanding of how to use Excel, how to collect information, and how to use the statistical softwares. But not anymore. You can just input that data into ChatGPT or chat and ask a question like what I'm seeing, what are the trends, what do you see that in this data sets that has actionable information that I can use. So it's much more simpler, I would say. And then these are simple prompts. You're simply asking the question, which is not possible before. We used to write programs for it. Now you can ask a simple query and it responds to you in real time.
Thank you, Dr. Ismail. Please, if anyone would like to make another question, please go ahead. Yes, Dr. Renato, please. Go ahead.
Yes, Dr. Ismaili, again, just insistent, just a quick question. Could you maybe share some of the resources where we could download specific AI that we can install in our equipment and start training it so that we keep our analysis private and not uploading any medical record to the clouds?
For sure. Yeah, I can. There's a couple of other tools, like Olama is one library that people use now very commonly. It's called OLLAMA, Olama, which is a built-in system that you can construct on your computer. Again, a little bit technical knowledge is required. The other thing is Hugging Face has a bunch of models that is free downloadable. These are open source models that you can use. A little bit technical required, not much, but you can start there, right? So you can. I can also suggest like so for example, if you want to work in Excel, right? Excel is a very commonly used like a program, and you want to do some statistical assessments. So I would recommend just go to ChatGPT and ask the question, says, what functions do I use in Excel to do these statistical work? And it gives you the answer, literally. It allows you to go step by step. So what you do is you're basically extracting the code from the ChatGPT to use it in Excel, get the inference that you're looking for. So all this thing could be built in-house, and you don't have to submit anything into any place. It gives
No.
you the understanding of how to run an Excel sheets. Yeah, you can do
The
it in
idea would
also.
be maybe to use the IA to provide an extract, a tiny extract of a huge medical record, because sometimes we have to deal with that. You have 100 pages of an old patient, and then you have to review that all and come to an analysis and a conclusion. And sometimes there is no time for that. And when you want to take advantage of AA to do that, you have the restrictions I just mentioned. So this could be an alternative for that, right?
This could be an alternative. Some institutions have now, in our institution, if you want to do that work, there's a HIPAA compliant level integration that's there. But then again, the cost and how much you're using that resources also come together as well. So institution provides that opportunity. For me, we have a supercomputer here in at Mount Sinai. So sometimes I just log in and run my task within the HIPAA compliant environment on a supercomputer. Everything is in-house. So those are options available. But I think simplistic design is to just do Excel, get the instruction from ChatGPT or whatever you use. I'm using ChatGPT because it's a very commonly known program, but there's Anthropic, there's other Gemini from Google, and
¿Eres normal?
other
¿Eres con 18? Nos
to
vemos.
basically respond to their queries or questions. It's very powerful. Very. If you've never learned, like for example, a SAS program or a R, most people have no clear understanding of how to code. You can ask. Then they give you instruction of step-by-step instruction of how to put information into an R program. Or run your first Python program. So there's a lot of opportunities that we never saw. You can simply ask questions in your language and provides you with the answers.
Do you think that Copilot, for example, in a control space, in a corporate space, could be APA compliant to do that kind of work?
Yeah, of course. That's how we experiment. That's how we start something. The paper that we wrote initially, we were almost done with our analysis, and suddenly this llama was released in open source, knowing that we can install it all inside our ecosystem gives us the opportunity to run the program, and it came out the very first early papers on the foundational work. So experimentation is, I would not disagree with you. That's how we learn. But I would not use anything that is real or it could be something that's synthetic, or it could be just made up. So it gives you an ability to test, and then you can apply it in the real world.
Thank you. Thank you. Appreciate it a lot. The input. Thank you.
Thank you, Dr. Renato, too. So Dr. Ismail, even though it was not part of your presentation, but I'm pretty sure that you probably have experience on this. Psychosocial risk factors are still a challenge, especially because of the confidential information and very delicate and complicated to talk about that. So if we want to implement or use artificial intelligence and digitalization of data that we can collect when we assess psychosocial risk factors, which would you recommend us to keep in mind to be very careful when we treat this information using the artificial intelligence?
It's a tough question. So, individual cases, the psychosocial information is very helpful, right? It does, like, for example, I showed you a person who's suffering from depression, anxiety. It's we understand that the trajectory from return to work will be challenging for those individuals. Um, so to answer this question, I think of aggregation. So if you have a, let's say, I don't know Peru that well, but let's talk about New York, right? New York has
Okay.
different boroughs, and Queens is different than Manhattan. Manhattan is very different than Brooklyn. Brooklyn is very different than Bronx. But each zip code, each borough has a different socio-economic characteristic that's built into this in these boroughs. If you've been to New York, you can see a wide difference between different boroughs. So if you aggregate the socioeconomic sort of pieces to a much more higher level than individual level, I think that that's a more comfort level for me. But you can apply it as a population-based socioeconomic sort of indicators, and that's acceptable. Like it's non-identifiable. It's focused on a population rather than individual, and I think that will give you a much more realistic picture of an environment, of a population, working population. I think it's a little bit challenging at an individual level. So because then you're able to identify a person. So I would work at more macro level to apply socioeconomic or psychosocial sort of analysis into my framework rather than doing it at the individual level. Hope that makes sense. That's less likely to be a challenging problem to solve.
So do you think maybe it would be better? I don't know if the term is better, but it would be helpful to use a qualitative study to explore the culture of the population where we are going to use the artificial intelligence, especially if we are going to focus on psychosocial risk factors, right?
Absolutely. Yeah. So qualitative research is really good in terms of that. Like you aggregate the responses. So you're not looking at one individual cases, but you can then decipher that in order to make inferences. No, I agree. As long as you avoid identification of a person or individual and then aggregate the information, that's much more powerful. So you can apply that. For example, a group of steel workers in a certain geographical neighborhood has a certain degree of similarity in a socioeconomic setting. A miner working in a certain area might have a similar sort of framework. Fishermen working in the coastal area has a similar kind of socioeconomic sort of patterns or framework that you can see. So I think adopting those might be a good way to move forward.
Okay. Thank you, Dr. Ismail. Please, if anyone from the attendees would like to make any other question. If not, it was really very interesting and helpful for all of us. Dr. Ismail, we would like to thank you and congratulations for your presentation.
Thanks for the invitation. I appreciate your help, and thanks everyone. Thank you.
Thank you, Doctor. And for ending this webinar, we would like to invite one of the ICO Peru members that is joining us today for making, like the closing remarks. It's one of the ICO Peru members that has been working hard in this digitalization of data and also in artificial intelligence. So Dr. David Sanchez is is a physician specialized in occupational and environmental medicine with a master's degree in biomedical informatics. He has been specializing in medical informatics, occupational health, medical auditing, data analytics, cybersecurity, and other topics related to data science. So it is really great to have you here, Dr. David. So welcome, and please, would you like to give some words about or share some experience of data digitalization and artificial intelligence in Peru? I will stop sharing the so you can share.
Hi, Dr. Neville, Dr. Norrin, and everyone. I hope you can hear me.
Yes, we can hear you.
Okay. Um, I'm sharing my screen. Maybe you can see.
It's working. It's working.
Uh, Thank you for all the words. Well, I will sum up and share some idea with you. Good afternoon, everyone. Thank you for being here and for your interest in improving workers' health by exploring how new technologies can support our field. First of all, I would like to thank the ICO National Secretary from Peru and the Scientific Committee of Occupational Medicine, SCOM, for this opportunity, and also extend my appreciation to the previous speaker, Mail Nabil, for a great presentation. It's really grateful to find someone that is also a physician and passionate for example, like me, in data and all AI technology, and share a lot of common interest in engineering projects. Well, my name is David Sanchez. I am a physician specialized in occupational health and also in medical informatics. I'm honored to share some insights today about how digitalization and artificial intelligence are transforming occupational health and safety. These changes are not in the distant future. They are already happening here. They are reshaping the way we understand and protect workers' well-being. Let me pass the PowerPoint. To begin, we need to understand the foundation, health data. According to the European Commission, health data enables more efficient, safer, and higher quality and more personalized care. So we can improve all our profession using knowing how to use the data. Think about how much data we generate today from medical records to wearable devices, tracking heart rate, for example, or our sleep. When we use this data wisely, we can predict health risks, design better interventions, and personalize care, even in occupational settings like mining or manufacturing or another industry. So we have to understand that all the artificial intelligence and tools we have now, it's a consequence of all the data that has been through to these large language models, so they can help us today. Artificial intelligence and data management are changing every step of the patient journey, or for us, the worker's journey, from early detection to follow up. We can find now any tools with artificial support, or not artificial support, but technological support in every step of the patient journey. For example, in many hospitals, speech-to-text tools are now allow physicians to focus on patients. We can hear them or listen to them, while AI generates clinical notes in real time. In some companies, for example, virtual assistants, also know that chatbots, for example, can help employees book medical checkups or access health advices in seconds, because they are connected to databases and clinical decision support systems. These tools do not replace professionals. That's a common mistake. They enhance their work and improve the worker experience or the patient experience, and also as to the professional experience. As we can see, for example, I have bring you to share a video. I hope it sounds okay. For example, we can use AI related to like computer vision, for example, improve models, for example, artificial intelligence in a particular exciting area here, AI in ergonomics. Because, for example, using this computer vision, companies now can detect touch postures real time. You don't need to take just a picture and then we usually does when you do the tests, the ergonomic tests we already know. These algorithms suggest adjustment before injuries can occur. In logistics, for example, and office settings, the artificial intelligence can analyze movements, the movement patterns to propose personalized ergonomic improvements, contributing to fewer musculoskeletal disorders, which remain a top occupational concerns that are globally known. And but for example, nowadays, what can I also teach here in Peru about AI use in healthcare? What's the public perception of AI in healthcare? However, no matter how advanced the tools are, we must consider how people feel about them. For example, in a 2024 US survey, revealed that many patients or professionals also still uneasy about AI involvement in their care. They are not confident with the AI using their health. This tells us that building public trust is essential. We need clear communication, transparency, and responsible use of the AI to ensure people understand what's the role of the AI and that is a supportive role, not substitutive. They are not substituting the physician when they are taking us, they are giving us human care. As you can see in the picture, no more than 70% of people believe that AI can help improve their areas of dominion. So it's something good, but you have to you have to share this confidence with the patients, also with other physicians. If we talk about Latin America and especially Peru in this time, digital health is no longer the future, as I said before, of our region, is the present. For example, we have rural communities, you know, and where apps are screening for mental health, the condition, and also using local language, not just Spanish or English that are common languages. In Chile, for example, AI tools, the artificial intelligence tools can assist with early cancer detection. In Peru, for example, Salud, one of the biggest public, I could say government companies that hold a lot of hospitals, has already integrated AI into electronic health records to support decision making across hundreds of facilities they have. And that's also supported by the electronic health records and their interoperability they can offer. Occupational health professional must ensure that we are part of this wave because AI has arrived and it won't go away. We have to know that applying these tools make us work safer and healthier, and we can bring that same idea to the patients. To sum up, because the idea is to share just a few conclusions and a few words with you. I can say that digital health is no longer the future, as it's day to day. We can use I'm sorry, we can use a lot of things, and we can learn about a lot of experience. Maybe here we are kind of newbies in using AI, and we think that AI can just do all the work we used to be. I've also been told, for example, to build a health record, an electronic health record, just using AI. So maybe today it's not possible, but using, for example, specialized AI like Llama or something like that, that was shown in the presentation before, it's an improvement with in the services we hold now. Just to finish and not to be bored with you, I would like to thank you all once again for your attention and for your time. I hope these insights can encourage you to continue exploring how digital transformation can enhance our ability to care for workers around the world, here in Latin America, in Peru, and everywhere. It's a pleasure to know that physicians and that are here in ICON in occupational health can now be interested in using new technologies and not to remain in in the stone area, like we can say. Uh, but this step by step. We don't hope that it will become one day from another to use AI and to can break all the bridges that, for example, Dr. Renato said. No, what we do with the data that we are sharing with the AI, and if we use a personalized data, maybe the cost of the computing process or the compute the it will be really increased, and maybe our costs are not our money. Well, the money is not worth it today. But for my final statement, I would say that let's keep innovating, collaborating, and learning, because the future of workers' health depend on it. Thank you so much again for the opportunity to share with you.
Thank you, Dr. David, for sharing not only the closing remarks, but also very inspiring message for us to involve more in artificial intelligence and data digitalization. Please, all the attendees, if you would like to make any question, Dr. David has presented and conducted in English, but of course he can also speak in Spanish if you want to make any question in Spanish. I would like to start, Dr. David, just like I asked Dr. Ismail, and of course, we are living in a very different context because he works and lives in the US, but considering Peru context and Latin American context, how would you recommend us to start working in artificial intelligence, not for big companies, but also for medium-scale enterprises?
Maybe, well, if I can answer in English, I think it's okay. But if if I fail, I can turn to the
Yes.
Spanish. Maybe the first of all, we have to get the people that we know digital alphabetization. A lot of physicians, a lot of workers in health, they don't know what. I prefer maybe to do it in Spanish. Muchas personas, o profesionales de salud, no están capacitados al día de hoy para hacer uso de muchas herramientas que en otras profesiones son comunes. Por ejemplo, en otras industrias, el uso de la inteligencia artificial lleva años, décadas. De por sí, la inteligencia artificial data de sus primeros inicios de 1950. En cambio, en salud hemos sido muy, como decir, muy prehistóricos en ese sentido y no hemos confiado en estas nuevas tecnologías. Lo primero que me ha tocado a mí en algunos escenarios es buscar esa masa crítica, ¿no? Personas capacitadas, entrenadas de qué es lo que verdaderamente significa entrenar un modelo de inteligencia artificial, trabajar un modelo lógico o un modelo sistemático para que esta inteligencia artificial resuelva uno o varios problemas, pero no hay forma de que los resuelva todos. Muchas veces cuando queremos una implementación, como mencioné y me ha pasado, quieren que la IA reemplace todo el trabajo al que estamos acostumbrados y muchas veces no retrocedemos al tema de los procesos. Y lo que hemos hecho en algunas organizaciones es primero implementar procesos adecuados y la IA o la inteligencia artificial cae sola por contexto, porque el proceso está ordenado, entonces es mucho más fácil pensemos en una inteligencia artificial como alguien que estamos capacitando. Si yo simplemente lo siento en una silla y le digo, haz, no me va a entender. Pero si yo le doy libros adecuados, guías adecuadas, manuales adecuados, lo va a hacer bien y lo va a hacer más rápido, ¿no? Es exactamente el mismo problema que se tiene que resolver para usar una IA adecuadamente.
Gracias, doctor David. Please, if any one of the attendees would like to make a question, si alguien quisiera hacer alguna pregunta, por favor, go ahead. Dr. David, I would like to make another question, please. If we try to work more on this, involve it in artificial intelligence, based on your experience here in Peru, which would be the hardest difficulties or the most complicated issues you had to face when you started working in artificial intelligence?
Hasta el día de hoy, en casi todas las implementaciones que me ha tocado participar de IA, ha habido dos problemas difíciles. Estamos hablando de salud y uno ha sido los mismos profesionales que se han sentido intimidados por la tecnología que los puede avasallar. Ahora, otro detalle en particular también, y eso ha incrementado, es que muchos de estos modelos que han sido importados tienen entrenamientos y conocimientos de una realidad que es diferente a la nuestra. Que eso es también algo interesante de entender en el tema de los sesgos del uso de la inteligencia artificial. Si nosotros queremos que resuelva problemas de América Latina, necesitamos haber entrenado una inteligencia artificial con data de América Latina, lo cual es un paso todavía lejano porque los países nórdicos tienen su información en salud digitalizada hace muchos más años y mucho más tiempo antes que nosotros, y tienen políticas de compartir esa información incluso con estos modelos de entrenamiento. Pensemos ahora hacia nuestra realidad, ¿no? O sea, si nosotros queremos ver la realidad de Perú o la realidad de, no sé, países como Bolivia, Chile, ¿qué tanto hemos compartido esa información para que luego la inteligencia artificial nos responda, nos dé una respuesta adecuada, ¿no? Entonces, eso ha sido por un lado. Y por el otro lado, la parte económica. Casi nunca existe un retorno inmediato, porque como le mencionaba el doctor Ismail, ¿no? O sea,
Right.
esta parte de IA todavía es un prueba de ensayo y error, ¿no? Vamos entrenando un modelo, lo probamos, a veces invertimos tiempo y dinero en un modelo y luego resulta que no era el adecuado o no era el problema o sea, resuelve un problema que no era el que estábamos tratando de resolver, ¿no? Entonces, un poco en esta parte de planeamiento y entender el verdadero problema que tenemos para ver si la IA nos está ayudando o nos va a ayudar, o si la solución que tenemos que implementar va por otro lado.
Gracias, doctor David. ¿Alguien más de los asistentes quisiera realizar alguna pregunta o algún comentario, ya sea para el doctor David o para el doctor Ismail? Okay. So thank you so much, Dr. Ismail Nabil, Dr. David Sanchez. It was really great to share with you during this afternoon. Um, we know about all the hard work that you have been doing, not only in artificial intelligence and digitalization, but also in different areas from occupational health and safety, which has been very motivated for us, uh, especially because we're commemorating this month and, of course, the 28th April as the World Day of Safety and Health and Work. Thank you to both of you. And for ending this webinar, the other very important part of this team for this webinar was the Scientific Committee on Occupational Medicine, ESCOM, and we have one member of the steering committee of this ESCOM ICO committee, which is Dr. Miriam Panduro. So I am glad to introduce you to Dr. Miriam Panduro, who is also ICO Peru member, is part of the organizing committee of the third conference on occupational medicine, which will be held in Peru. And we invite you from now to come to Lima, Peru. So, Dr. Miriam, it is an honor to have you here. And please, you would like to end this webinar?
Well, thank you, Norville. Hello, everyone. I'm Miriam Panduro, and on behalf of Scientific Committee on Occupational Medicine, we would like to thank ICO Peru for organizing a great talk. It is indeed the most important matter of this era for occupational practitioners. My gratitude to Dr. Norville for taking the trouble to showcase the needful subject, especially in conjunction with ILO World Safety Day. Not forgetting Dr. Ismail for sharing his deep experience in this field. And we hope that the information provided will be very useful to all of you. Thank you, Dr. Ismail. We also appreciate the participation of Dr. David Sanchez, who has given us insights into the use of artificial intelligence in Latin America and especially in Peru. And I would like to have this opportunity to welcome to all of you to join the third International Conference on Occupational Medicine in Lima, Peru, in December 11 to 13, 2025. I'm sure you will gain a lot of knowledge and information at the conference. So for people all over the world, don't miss the best food and the beautiful places, which you will never forget. Please, you can visit the ICO website for further information. And well, thank you again to everyone. Have a nice week. En español, bueno, por parte del Comité Científico de Medicina Ocupacional de ICO, agradecemos la participación del doctor Ismail Nabil y el doctor David Sánchez en este importante webinar. Agradecemos su asistencia y los invitamos a ser parte de esta tercera conferencia de medicina ocupacional este 11 y 13 de diciembre acá en Lima, Perú. Las inscripciones ya están abiertas, pueden mandar también sus abstracts para los pósters y presentaciones orales. Muchas gracias y que tengan una linda semana.
Gracias. Thank you, Dr. Miriam. Thank you all. I have copied the link for registration if you want to get access for the recordings of this webinar and the recordings of the previous webinars that as ICO Peru we have worked on. You can register in this link and then we will share with you the link for access to all the webinars. So thank you all and we hope to see you very soon. And of course, we look forward to meet you here in Peru for the third conference. Thank you and have a good and nice afternoon.
Gracias, Doc. Saludos.
Gracias.
Gracias,
a todos.
doctora. Gracias a todos.
Gracias a todos.